All right, I hope everyone had a good lunch. I'll present our next case, which is robotic nephroureterectomy. We're doing the right side today. So our patient is a 75-year-old female Jehovah's Witness with a 30-plus pack-year smoking history who came to us with a diagnosis of high-grade papillary urothelial carcinoma of the upper pulvar right kidney. So this was actually incidentally found back in May. She was hospitalized for duodenal ulcers that were bleeding and required emergent endoscopy and fulguration. Actually, her hemoglobin had dropped to 5 and she required pretty significant resuscitation. She does not take blood products given her Jehovah's Witness beliefs. So initial imaging studies that were done there during her hospitalization demonstrated this mass, and then she had a formal CT urogram later during that admission, which confirmed a right upper pole filling defect. She had a staging chest x-ray that was negative. She was referred to her local urologist and in June underwent cysto, right retrograde pyelogram, right ureteroscopy, and biopsy along with a stent placement. And her urologist found a high volume tumor in her entire right upper pole making its way down to the renal pelvis. The urologist took some biopsies and did show non-invasive UC, but that it was high grade. Review systems, she's been having low-grade fever since January. She had a 20-pound initial weight loss, has gained back some weight since then, and has had hematuria on and off over the last year. Past medical history, she's pretty frail appearing and has a history of COPD, asthma, type 2 AV block, the duodenal ulcers, hypertension, arthritis, bipolar, chronic pain, and has a surgical history significant for hysterectomy back in the 1960s and appendectomy back in the 1950s. Family history is non-contributory. Social history, the aforementioned smoking, multiple medications, multiple inhalers, antihypertensives, statins. Exam didn't show any adenopathy, and her labs did demonstrate creatinine of 0.9 with a somewhat diminished GFR of 60. Other labs were unremarkable, and her H&H actually has come back up nicely to 13 and 40 with iron supplementation. We did do a preoperative renogram on her and demonstrated pretty much even function between the two kidneys. We had a pretty long and detailed conversation with her about having neoadjuvant chemotherapy prior to surgical intervention, but she strongly preferred surgery first. And that's what we're going to proceed with. We did do a repeat CT scan in August to make sure there were no new findings, and there was no evidence of adenopathy or metastatic disease. There's our CT scan, axial scan. And scrolling down, you can see right there, you can see filling defects come into view in the right upper pole there. Right there. The rest of the ureter was fairly unremarkable. And then again, the coronal view. Some soft tissue densities up there in the upper pole. Dr. Porter talked about this prior to the lunch break, so I won't belabor these points, but with the XI, we do have a bit of an easier time with nephroureterectomy in terms of doing all this in a single docking. We don't use any additional ports, and we can get to the bladder fairly easily and do a nice bladder cuff and watertight closure, and we routinely do an RPLND with these cases. Again, the patient positioning, the head's to the left of the picture, the feet are to the right. You can see we use a linear port array, but somewhat diagonal fashion, going from lateral to medial as we make our way down to the bladder. Again, the same configuration here in this figure, and you can see where the assist port is as well. And we bring the robot in to the side, kind of midway along our working path. So without further ado, we'll get to Dr. Porter.